again, cellular immunity, different parts of neural immunity or cellular immunity, innate immunity, all of them will be reviewed today again in both lectures. So what does hypersensitivity mean?
Abnormal immune response.
Abnormal immune response, yes.
To the damage of tissue.
That's lead to abnormal immune responses that lead to tissue damage. What else?
Unwanted immune response to non-self at the G cell.
Unwanted immune response against non-self antigens. Only non-self antigens
And also self-antigens.
and also self, both of them. So unwanted immune responses against both non-self and self antigens. It's important. Both of them are targeted in different forms of hypersensitivity that you know many things about them now. Indeed, they are overreaction of immune response against harmless antigens, or even sometimes harmful antigens. Normal immune response against pathogens, microorganisms, we need to control the infection. But sometimes overreaction of immune response against pathogen would damage our tissues. So overreaction of immune response against any antigen, pathogenic and non-pathogenic, harmless and harmful, self and non-self, is called hypersensitivity, that we have unwanted damages by immune system to the body. So we will talk about 4 different types of hypersensitivity reactions, and indeed we will focus on immunological mechanisms of them. We will talk about some diseases in very shortly, not in details. About the diseases that today I'm going to talk about them, you will have, I've told you, some lectures in your clinical courses. But today I mainly focus on immunological mechanisms behind hypersensitivity reaction and some diseases related to these reactions. The first one is type 1 hypersensitivity, which is called IgE mediated mast cell degranulation. Another one is called type 2 or antibody dependent cytotoxicity. It's not, it's better to say antibody dependent reactions, not just cytotoxicity. Sometimes we have antibody dependent reactions in type 2 hypersensitivity that they are not, we do not have cytotoxicity in them. So all of them do not have, in the second type, all the reactions are not cytotoxicity reactions. Some of them are cytotoxicity reactions of immune. Cytotoxicity means killing of cell with another cell or with complement. Cell killing. It's another term for cell killing, cell death. But not. It might be by apoptosis or necrosis or other mechanisms of cell death. Type 3 hypersensitivity, it's immune complex mediated. You know what immune complex is, and you know how immune complexes can trigger inflammation and tissue damage. And type 4 hypersensitivity, which is cell mediated reactions, and they are called delayed type. So you can see here again, the type 1 is IgE, this one is allergen, IgE, Fc receptor, you know all of them. Fc receptor, mast cell, and then the granulation of the mast cell. Indeed, by binding of allergen to IgEs on the membrane of mast cells, that we know that those IgEs are bound to mast cells by Fc receptors. And after binding of allergen to those IgEs, we will have activation of mast cell and the granulation of it, and everything that happens in the first type or allergic reactions are as a result of the granulation of the mast cell and eosinophil cell. And the content of the granules of mast cell is indeed the main culprit of all things that happen in type 1 immune reaction, hypersensitivity. In type 2 hypersensitivity, we have again antibody against target cells, but the type of antibody is different. Here we have IgE, but here we have mainly IgG and sometimes IgM, but mainly IgG. And the cells are different, and the whole story is different. Sometimes we have activation of complement. Type 3, we have immune complexes. Complexes made of multiple antigens and antibody that they are attached to each other, and now they can bind to Fc receptors again in different cells, and we have the position or trapping of these immune complexes on the blood vessels, mainly capillaries. That in the capillaries we have activation of complement again and inflammation. In the type 4, we have a T cell mediated immune response and cellular immune. So the three first types of hypersensitivity, all of them are antibody mediated. The first one by IgE and mast cell, the second one IgG and some other reactions, and the third one as a result of immune complexes. And you know the exact mechanisms of all of these immune responses, but the story here is that we have those kind of immune responses. Until now, we have talked about those immune responses normally against cancer, normally against microorganisms, but here we have unwanted immune responses against the antigens or overreaction of immune responses, unwanted overreaction of immune responses against self or non-self antigens. That indeed in those diseases we have tissue damages, that this tissue damage is a result of immune response, not the, for example, microorganism directly. As a result of overreaction for some microorganisms or unwanted immune response against self-antigens, we have tissue damages that is made by immune responses, immune cells, complement activation, or other mechanisms. So, type 1 hypersensitivity or allergy. Angioedema is a case of anaphylaxis as a result of, you can see here, edema here in the patient. He has allergy, for example, I do not know for what, I do not remember, it might be for, it can be a reaction for food antigens, systemic antigens, or even airborne antigens, anything. That it has activated mast cells, and as a result of the granulation of the mast cells, we have inflammation, and as a result of inflammation, we have edema here. And here again, we have edema in just one eye and around the right eye of this patient. There are different allergic reactions. There, indeed, you can see there. There are indeed erythema, and I think indeed urticaria or hives reactions. You can see both of them, all of them are IgE mediated responses. So what happens? Indeed, we have IgE mediated hypersensitivity or allergic reactions. So all the reactions are not called allergic reactions. All allergic reactions is just used for IgE mediated hypersensitivity. That results in production of IgE toward innocuous or harmless antigens, including pollens. You know that pollens are not harmful for us. Or all of the allergens, different types of allergens, the allergen itself is not harmful for us, but immune response against them causes some tissue damages. What is an allergen? What is a simple definition for allergen? Give me a simple definition for allergen. Nothing? When you hear allergen, what comes to your mind? Anything that comes to your mind when you hear allergen. It's an antigen, yes. What else? What kind of antigen? No, most of the allergens are not self. For example, pollen, or insect bites, or venom, snake venom. They are non-self. Antigens, but non-self antigens. Here, we are talking about type 1 hypersensitivity here. What else about allergen? Antigens, non-self antigens, harmless non-self antigens. They are indeed a kind of immunogens. But those immunogens induce IgE-mediated immune response. Okay? They are harmless antigens or harmless immunogens that induce IgE-mediated immune response. That's it. They are antigens. We have different kind of antigens. You know that all antigens are not immunogens. Some of them are immunogen. Immunogen means any antigen that can induce immune responses. Any antigen. And
Also the drug can cause allergy.
drug, yes. Yes, some point, for example, penicillin. But the type of hypersensitive allergy is different for different drugs. Sometimes we have type 2 immune response against some drugs. Sometimes we have type 1. So they are highly soluble proteins. So they are proteins. It's very important. They are not carbohydrates. They are not nucleic acid. They are not lipid. Why? Why allergens are not nucleic acid, carbohydrate, and lipid? They are just proteins. What's the reason behind it?
Because in this state and trigger T helper 2 response. T cell can make immune response if it's bind to MHC receptor by a protein. Just
Yes.
the inner.
Yes. When we have IgE, whenever we have antibodies other than IgM, keep in mind. Whenever, in all immune responses, generally, not just here, when we have antibodies other than IgM, IgE, IgG, or IgA, that here we have IgE, it means that we have had class switching. And class switching needs T cell help. And T cell help, when we have T cell help, it means that just proteins can activate T cells. So just proteins are allergens because we need IgE against them. We cannot, when there is, for example, against antigen of carbohydrate, we won't have T cell help. When there is no T cell help, we won't have IgE. When there is no IgE, there is no allergic reaction. Clear? There are soluble protein, all of them are important. Mainly they enter the body at very low doses by diffusion across mucosal surfaces and trigger type 2 immune response, TLR1, TLR2 immune responses. Atopy means generation of inappropriate level of IgE against anything. Having inappropriate high level of IgE means atopy. Indeed, it's a susceptibility to IgE, to allergic reactions. So it's indeed a natural inherited body tendency or susceptibility to develop allergies. Atopy means this, having high level of IgE, that this one means the second one, inherited tendency to develop allergies, or inherited body tendency to produce high level of IgE. All of them are different definitions of atopy. There is a common term in allergic reactions, type 1 hypersensitivity, which is called allergic march. It's better to write allergic march or atopic march. What does that mean? It means a typical progression of allergic conditions, different allergic manifestations, progression of different allergic conditions or manifestations that often begins from after birth, from infancy, and develops through childhood. You can see here, this is about 1%. That after birth to 1 year old, mainly it begins with eczema, skin-related allergic reaction, and then in that patient, when the baby grows older, the manifestation changes to food allergy, and over time in that person, the manifestation changes to asthma, respiratory reactions, and then rhinitis, upper respiratory reactions. So indeed this is changing of manifestation of the disease or allergic reactions in one person over time, and it begins from infancy to childhood, and it's and always this pattern is not stable. Sometimes we have different patterns, but when we have, for example, eczema in a children, in a child, we expect, for example, after 1 year, it changes the allergic reaction to food allergy and other allergic over time. It shows that this person, it is called atopic march. It shows that this person has tendency to develop allergy to different allergens in different tissues, target organs. So the story is saying this person has tendency to produce IgE as a result of its genetic and its environmental factors. It has tendency to produce IgE against allergens, external allergens, but the target organ changes over time only. The story is saying he has, for example, IgE against one allergen, and first of all, we have involvement of skin, then just the target organ changes. Okay? No question? So it is called allergic march or atopic march. This is, you are not going to memorize, it's not needed, the content of this table. You can see different types of allergens, insect products, mainly from dust mites, or companion animals, pets, including cats, dog, and trees. You know that trees can produce different kinds of allergens. Allergens of grass and plants, again, different types, molds, foods, drugs. For example, we have allergic reaction against penicillin or other types of drugs, and occupational allergens, including, for example, toluene. For the people that works with some chemical agents, some people have allergic to latex. Latex is used in some gloves, and some others. So there are examples of different allergens, and the type of allergens is known for most of them. So there is no need to memorize the content of the table. What are the risk factors for developing allergy? Risk factors means something that increase the susceptibility to induce allergy. First one is genetic, family history. Family history is a sign of genetic. For example, in a family that none of the parents has a history of allergy, the children has around, for example, 50% chance of developing allergy. But with a person that one of his parents or her parents has a history of allergy, it has around 30% to develop allergy. But in a child that both of his parents or her parents have a history of allergy, it has higher chance of developing allergy. It shows a family history in the families that there are a history of allergy, so the other siblings, the children have higher chance to develop allergy. It shows the involvement of genetic factors. Okay? Another factor is serum IgE, and again it's indeed a genetic effect in the persons. When the level of IgE in the blood increases, the chance of induction of allergic reaction increase mainly when it's more than 1 microgram per milliliter. So having high level of IgE or history of allergy in the family, they are the factors that shows that the chance of induction of allergic reactions is higher compared to the family. For example, that there is no history of family for history of allergy in the family members. And it's important to know that interplay between, it's like all immune responses, environmental factors and genetics, both of them are involved. Environmental factors is clear, exposure to pollens. When a person has genetic background but not exposure to the pollen, so it won't have any allergic reaction to the pollen. But on the other hand, genetic factors that I talked about them are involved in induction of allergic reactions. So what happens in type 1 allergic reaction? In the immunological mechanisms of induction of immune response, allergic reaction. The first step is presentation of antigen by APC to CD4 positive T cells, and development of CD4 positive T cells to T helper 2 as a result of presence of IL-4 is important for development of T helper 2. And when a B cell and a T helper 2 will produce interleukin 4 and interleukin 13, and moreover, you know that B cell is an APC, and allergen is presented by the B cell to the T cell that is now T helper 2, and the production of cytokines including interleukin 4 and 13. We will have class switching of the antibody to our IgE. So presentation of, so we have involvement of APC, production of IL-2, IL-13, and class switching of antibody from, you can see here that this one is a naive B cell. I've told you, any B cell having just IgD and IgM on its membrane, it's called a naive B cell. But after receiving help from CD4 positive T helper 2 cells, it will change the class of antibody to IgE. So now we have some B cells, memory B cells, that their antibody on their surface is IgE, and some plasma cells that they produce IgE. And those IgEs have receptor on the membrane of mast cells and eosinophils. They are Fc receptors. And now those anti-IgEs can bind to the mast cells by their Fc part, not by the antigen binding site. Those part is specific to allergen, not mast cell. The IgEs are binding to mast cell by the FSC to Fc receptor on the membrane of mast cells or eosinophils. Until now, so this is the first exposure to allergen, and it is called sensitization step. Until now, we won't have any clinical manifestation. We have just, until now, we had just production of IgE and binding of IgE to the mast cells. If we have other exposure to the allergen, in the second exposure, now allergens can bind to the IgEs that they are attached to the Fc receptors of the mast cells. And by bridging of two IgEs together by allergen, we will have activation of the mast cell. So in the first step, we have exposure to allergen and immune response against allergen, activation of B cells, APCs, T helper 2, production of interleukin 13, class switching to IgE, development of B cells to plasma cells, production of IgEs and binding of those IgEs to the mast cells. Until now, we have just sensitized mast cells. It is said the first exposure to the allergen just leads to sensitization of the mast cells. It's just sensitization step. In the next step and second exposure to allergen, it can occur over time or in the next exposure to the allergen. The allergen has two bridges between two IgEs that they are bound to Fc receptors of the mast cells. When one allergen makes this bridge, we will have activation of the mast cell and releasing of the content of the mast cell, the granules of the mast cell. And there are several types of material in the granules of the mast cells that they have different effects. For example, they have effects on smooth muscles, small blood vessels, mucus production, blood platelets, sensory nerve endings, eosinophil activations, and some others. Clear? This is the whole story of immunological reactions of type 1 hypersensitivity. And the second phase is called the granulation phase. The first phase is called sensitization. The second phase is called the granulation. Also, the granulation of the mast cell is lead to the. Now we will have the clinical manifestations. So before here, we do not have any. There is no clinical manifestation. You won't see anything in the patient. But after the granulation, we will have different manifestations. So we have CD4 THR2 involvement and interleukin 4 and 13 cytokines involvement and class switching from IgM to IgE. So you know that for class switching we need those cytokines and direct cell contact between THR2 and B cells. So low doses of antigen favor activation of THR2. That's why I said that they are soluble small molecules that we are encountered with them in usually low doses. So it requires binding of CD40 and CD40 ligand between B cells and THR2. You know anything about them? Without binding of CD40 ligand to CD40, we won't have class switching. So we need those cytokines produced by THR2, and these two signals is required for IgE class switching. So those two signals, both of them, are required for class switching to IgE. So the allergic reactions, the allergens indeed that induce allergic reactions or IgE-mediated immune responses, they are T-dependent or thymus-dependent antigens. You know the difference between T-dependent and T-independent antigens. What's the difference between them? Bernard? Wait, please. The differences between T-dependent and T-independent antigens. And we know that all allergens are T-dependent. What does that mean?
That activates B cell.
Which one, T-dependent or T-independent?
T-dependent, because it's dependent on T cell to activate B cell.
Yes. The name shows T-dependent. T comes from T cell response. So T-dependent antigens are those antigens that needs T help. Indeed, they can activate T helpers. And we have the help of T cell and B cell as well. So that we have the different immune responses, including class switching. And T-independent, they are independent to T cell. There is no T cell help. They are opposite to the previous one. So in the first one, we have T cell help. In the second one, T independent, we do not have T cell help because they are non-proteins. And non-proteins cannot bind to MHC and they cannot activate T cells. MHC is needed for T cell activation. Without MHC, we do not have any T cell activation. So non-proteins, we know that they cannot bind to MHC, so they cannot activate T cells. And here we have IgE production, T helper 2 responses. So when we have T cell response besides B cell activation, so the antigen is T dependent. That's why I told you that all allergens are proteins or T dependent antigens. And in the research, animals that do not have T cells, they won't produce IgE. It's logical. When there is no T cell, there is no T cell help, there is no CD40 ligand signaling, there is no interleukin 4 and 13, so we won't have class switching. And again, in the research labs, animals without mast cells cannot make IgE mediated inflammation. So we have both mast cells and IgE and T cells. So all the networks here, all members of this slide, all of them are needed for IgE production or allergic reactions. Both B cells immune response, T helper 2, class switching, mast cells, and degranulation of the mast cells. So the mediators released from mast cells are categorized in two groups. Different kinds of mediators are released from the mast cells. This slide is about the things that mast cells release to induce clinical manifestations that we see in allergic reactions. Different products are produced by mast cells, including some enzymes, some toxic mediators, different kind of cytokines, chemokines. What is chemokine? Chemokine. Yes, it's a type of cytokine. But what kind of cytokine?
Chemical?
Chemotaxis. Cytokines that are involved in chemotaxis. Chemotaxis means migration, moving of cells from, for example, the blood to the site of, when we have inflammation, do you remember? In the inflammation, this is the blood vessels, cells are here, and here, for example, it's the skin. And if we have bacteria here, we will have inflammation. And as a result of inflammation, we have calling of the cells to the site of infection. And when we have exit of cells from here and movement toward of the bacteria, this process exit from the blood and moving toward the bacteria is called chemotaxis. And chemokines are involved in the movement, in the migration of the cells from the blood vessels to the site of infection or immune response. So they are cytokines that mediate cell migration, cell movement from one place to another place. And lipid mediators, including different leukotrienes, some prostaglandins and platelet activating factors, different kind of cytokines, interleukin 4 and 13. They are type 2 cytokines, TLR2 cytokines, interleukin 5 that activates eosinophils, and TNF alpha, it's a pro-inflammatory cytokine, induce the inflammatory reactions. But those mediators, all of them are products of mast cells. All of those things are products of mast cells that each one do something in the body. The biological effects is different. For example, enzymes are involved in the remodeling of the connective tissue. They cut something in the connective tissue and remodel the connective tissue. Toxic mediators, including histamine and heparin, you know that they have effect on the blood vessels, they increase the vascular permeability, they cause smooth muscle contraction around the blood vessels, and cytokines that you know that those cytokines are involved in production of TLR2 and interleukin 5 activate eosinophilic activity, and TNF alpha is pro-inflammatory cytokines. Chemokines are involved movement of cells, and those leukotrienes they are important in, again, they act on smooth muscles contraction again. They increase vascular permeability, and platelet activating factors, as the name shows, they are main activator of platelets. So all of them are produced by mast cells, but they are categorized in two groups. The first group are indeed, they are preformed materials. Before activation of the mast cells, they are produced and stored in the granules of the mast cells. So they are preformed granules. As they are preformed granules, they induce immediate hypersensitivity reaction. The reactions that after few minutes of intolerance of allergy we see, they are indeed the effect of preformed granules content, including enzymes and toxic mediators, histamine and heparin. You know histamine. And the second group is the products that needs to be synthesized. They have to be made after activation. Before activation of mast cell, we do not have those things, the second groups in the granules. But after activations, mast cells will begin to produce them. So the production of them takes time. That's why they are responsible for late phase reactions after few hours. So they are after few minutes, the induce reactions after few minutes, the first groups, and the second groups induce reactions after few hours, because mast cells needs time to produce them. But the first group, they are preformed. Mast cell, just before activation, mast cell has produced them and stored them inside their granules. Is that clear? Question, comment? So this table is about the contents of the granules of the mast cells. Two groups, preformed, synthesized, or the things that are made after activation. And the second group, you can see that we have cytokines here, leukotrienes and inflammatory cytokines, so they are highly inflammatory. So the different components inside the granules of this is a mast cell, resting mast cell, and this one is activated mast cell after degranulation. You can see the changes on his membrane, and even you can see here many granules inside the mast cell, but after activation the number of granules is decreased remarkably here. And based on the different mediators, products that are released from the granules of the mast cells, we have different effects that you saw them in the previous slide. So it's again, no, we can escape from this slide. It's the summary of, so the primary effects and secondary effects there are another term for the immediate responses and late responses mediated by different contents of the mast cells. And the effects of histamine, we can skip them. All of them, we have all of them in that table. So the first table is enough. And I think the best table, better table for this. So this table is very important again, because based on the type of allergen and the route of entry of the allergen, it's important to know that based on the type of allergens and the route of entry, we will have different responses or different kind of syndromes. For example, for the allergens like this, you do not need to memorize the name of the allergens here, but knowing the routes is important. For example, if we have intravenous directly injecting the allergen in the blood, for example, by injection of penicillin, for example, by intravenous exposure to the antigen, we will have systemic anaphylaxis. Anaphylactic reactions are indeed the inflammatory reactions in the allergy. So we have systemic because the antigens go direct to the blood, and it can affect different organs, several organs. So we will have edema in most of the body. You saw in the first images, and as a result of increased vascular permeability, we might have tracheal occlusion, or circulatory collapse, or other manifestations. So the route of entry is intravenous, directly to the blood. If the allergen comes from the skin, so the main manifestations are indeed on the skin, including acute urticaria. Or if we inhale the allergen, the reactions would be in the respiratory tract, allergic rhinitis. And another, indeed it is upper respiratory tract, and another type of inhalation is asthma. It's indeed involvement of lower respiratory tract. And if we get the allergen oral, we will have food allergy is a good example, and we have involvement of GI tract, including vomiting, diarrhea, pruritus, and some other manifestations. So both the type of allergen and the route of entry is important in the development of the type of the allergic reaction. For example, in atopic march, the reaction was started by this one, and then it changes to different manifestations, because the route of entry changes over time. For example, entry of the allergen, I mean. So both environmental factors, including air pollution, in developed countries that the hygienic condition is different, low gut microbial diversity is very important, which means dysbiosis, the microbiome of the gut is very important in allergy, low fiber diets, or farm environment and different exposure to different kind of allergens, and genetics. That genetics are involved in different aspects of immune responses. For example, when a person has gene polymorphisms in the receptors of mast cell, indeed a person has a hyperreactive mast cell. So it has a higher susceptibility to develop allergy compared to a person that do not have a hyperreactive mast cell. So both genetic factors and environmental factors, both of them are involved in induction of allergic reactions. This is a skin prick test that is used to test to detect the allergy. To check, for example, we want to check a person has allergy with against allergic reaction against which kind of allergens. We have injection of different allergens on the skin, and then we check the reactions. So here, for example, there is a reaction here. This reaction is called Wiener-Flare. Wiener-Flare means, for example, erythematic and, for example, edematic reaction. Both redness, we have a redness and a central edema with the surrounding erythematous reaction. So this is called a Wiener-Flare reaction against just grass allergens. So the prick test is done to check if the patient has allergy to which kind of allergens. And you can see here Wiener-Flare. This one is this surrounding. This one is indeed V, and this one is Wiener-Flare. And sometimes we can measure the level of IgE, which is routinely measured in the medical laboratory. For the treatment of allergy, the first thing and the most effective way for the treatment of allergy is allergen avoidance. Is the most effective and mostly it's accessible. And the other one is hyposensitization or desensitizing the patient. It's a medical process, and using monoclonal antibodies. What is a monoclonal antibody? I've told you. monoclonal antibody. A simple definition for monoclonal antibody. Ya Allah, please.
Population of T or B lymphocytes that have a receptor against a specific epitope.
No.
Same.
A population of antibodies that all of them are against just one epitope. The specificity of all of them is same. Okay? When we have a population or a vial of antibody, it's full of antibody, for example, 1 milligram of antibody, that all of those antibodies are against just one epitope. Indeed, all of them are produced by one clone of the antibody. You do not need to memorize everything. You can look at the name, monoclone. You know the clone. Clone is a population of B cells that all of them are against one epitope. So the antibody which is produced by one clone, it means that all of them are against one epitope. Okay? Monoclonal. On the other hand, we have polyclonal. Polyclonal means production of antibody with several clones or many clones. The main problem with your exam is that you want to memorize everything. It's not possible to memorize everything from beginning to the end of the lectures, all the lectures, the courses, all the courses. You should know how to study, and you have had the exam once before, and now you do not need to, you should focus on the concepts and some important things that we need to memorize. Just some of the things we need to memorize them, not all of the things. The rest of the things are conceptual. For example, activation of I have repeated class switching of the antibody from IgM to the other classes several times in the class. That it needs T cell help, it needs cytokine, it needs CD40 ligand. That's it. Class switching is this, nothing else. 3 sentences. B cell activation, T cell help, cytokines, CD40 ligand involvement. For class switching, we need all of them. That's it. So you do not need to memorize. You should try to understand the concepts behind the immune responses. And the immune responses is same against the process that are involved. Is same against microorganisms. We have same mechanisms of immune response against tumors, against in hypersensitive reactions, in all of the diseases. We have just some components in immune response: humoral immune response, cellular immune response, and innate immune response. If you know this component that you know, just you should think about them. You do not need to memorize that what you have heard about them. You should just think about innate immunity. I know that in innate immunity we have macrophages, NK cells, neutrophils, and if you know the functions of those cells, you can answer most of the questions about innate immunity. And if you know the process, the total process of humoral immune responses and the cells that are involved, the components that are involved, you can answer most of the questions about humoral immune responses. You do not need to memorize everything instead of thinking about the concepts. And several monoclonal antibodies now are being used in the laboratory to treat allergic reactions, including, for example, antibody against IgE or antibody against interleukin 4 and 13. Monoclonal antibodies, indeed, they are neutralizing antibodies that they bind to, for example, those cytokines. When those antibodies bind to those cytokines, and when those cytokines are neutralized, it means that we do not have T cell help for B cell, because those cytokines are indeed eliminated from the environment by those monoclonal antibodies and some other monoclonal antibodies. Other drugs, including antihistamines, you can study them from the slides. You need to study those slides. And epinephrine and cortisone with different actions, you know them. They are pharmacology, and you have had some courses about different drugs. That's enough for the type 1 hypersensitivity. Clear? IgE mediated, B cell involvement, IgE production, T helper 2, so we need They are T dependent because the antigen is protein, and for protein we just have IgE. Whenever we have class switching, so the antigen of course is protein. That's the whole story of type 1 hypersensitivity. So we can have 10 minutes rest. Please get back